Hello everyone, my name is Quy Tran and the title of this presentation is Prognostication for the Palliative Care Provider. This presentation will focus on the basics of prognostication and predicting survival in terminally ill patients. First, some disclosure information. I have no relevant financial relationships to disclose. No honoraria or payment was accepted for this presentation, and all opinions are strictly my own. Let's start with a case study. This is a 55-year-old Asian woman, never smoker. She has a history of heavily treated stage 4 non-small cell lung cancer metastatic to brain and bone. Her original diagnosis was about 8 months prior. She has a history of right lower leg DVT and PE and is on full-dose anticoagulation. She presents with left-sided weakness and fatigue. The weakness then included right-sided deficits. An MRI of the brain revealed scattered acute infarcts in the bifrontal region, bilateral cerebral region, right MCA region, right caudate body, and thalamus. There was high-grade occlusion of the proximal right middle cerebral artery, and there was concern for midline shift and herniation. Question: based on this information, what is your predicted prognosis? A. Less than 1 week. B. Less than 1 month. C. 1 to 3 months. D. 3 to 6 months. Or E. Greater than 6 months. The patient was then transferred to the MICU for aggressive care. The patient's status soon deteriorated. Palliative care was called for a goals of care discussion, and a family meeting resulted in transition to comfort measures only. The prognosis was then estimated at hours to days. Question: how well do clinicians do in predicting prognosis? A. We tend to underestimate survival. B. We are always perfect. C. We tend to overestimate survival. This is a partial listing of studies that recorded how accurate physicians are in prognostication. The second column shows median survival in weeks, while the third column shows median actual survival in weeks. The last column is the ratio of the two, with ratios greater than 1 indicating a bias toward overprognostication. In these cases, you can see that physicians tend to overestimate by a factor of 1.2 times to 5.3 times. Just to emphasize the idea that physicians tend to overprognosticate, here is a survival curve on 300 terminally ill cancer patients, as noted in the black survival curve. The median actual survival was 24 days. Physicians tended to overprognosticate by a factor of 3, leading to a median formulated survival of 75 days, as noted in the blue survival curve. Yet only about 1/3 of physicians in this study actually communicated their own estimate, while 2/3 of physicians either provided no survival estimate or knowingly provided inaccurate estimates. This translated into a median survival that was communicated to the patients of 90 days, as noted in the red survival curve. Given that physicians tend to overestimate survival, for this case presentation, how would you go about creating a reasonable formulated prognosis? In its simplest terms, a formulated prognosis contains varying amounts of 4 key elements: performance status, symptom burden, objective signs, and clinician estimate. The vast majority of prognostic models contain one or more of these variables, and understanding these relationships can help you formulate a prognosis. First, performance status is a global measure of a patient's functional capacity and has been shown to predict survival in patients near the end of life. Several different performance status metrics have been developed to quantify performance status, including the Karnofsky performance status, or KPS, Palliative performance status, or PPS, and ECOG performance status. The KPS ranges from values of 100, signifying normal functional status with no complaints nor evidence of disease, to 0, signifying death. The ECOG performance status goes in the opposite direction, with 0 signifying normal functional status and 5 signifying death. For our patient case then, a KPS of 20% would be reasonable. Multiple studies have reported associations between the patient's performance status and their subsequent survival, with lower performance status predicting shorter survivals. The size of the association is described differently in different studies depending on the statistical methods used, but several studies reported that among patients enrolled in palliative care programs, a KPS of less than 50% suggests a life expectancy of fewer than 8 weeks. For this patient case, a KPS of 20% will put the median survival between 7 to 16 days. For patients with cancer, the American Joint Committee on Cancer publishes a staging handbook which oftentimes includes survival curves. The one that I put up is for non-small cell lung cancer, with stage 1 at the top of the chart and stage 4 at the bottom. The patient was about 8 months since her diagnosis. Plotting this on a chart, about 30 to 35% of patients with stage 4 disease are alive at 8 months, so this gave us a rough estimate where she was in her disease course. Since the patient had an acute stroke, you could also calculate the National Institute of Health stroke score. This number can be plotted on either a 7-day or 3-month outcome curve. The y-axis here is the probability of an excellent outcome. With their score 27, the patient had a 2% chance of an excellent outcome. Said another way, the patient had about a 98% chance of either severe disability or death. This gives us another data point to estimate her prognosis. To give additional prognostic data points, you can look at models that try to combine performance status with symptom burden. This one is called the Palliative Prognostic Index, which was developed and validated on cohorts of terminally ill cancer patients. The index takes performance status, oral intake, edema, dyspnea, and delirium, and assigns a numerical score to each of these variables. The total score can then be used to estimate survival. For this patient, the total score was 11 points, which put the patient at a median survival of 12 days, and given her high score, likely much less than this. Based on prior experience, prognostic models based only on patient-centric variables tend to be less accurate than those based on both patient-centric variables and clinician predictions. The palliative prognostic score was tested and validated in terminally ill cancer patients enrolled into hospice. It takes performance status, the symptoms of anorexia and dyspnea, objective findings including white blood cell count and lymphocyte percentage, and modifies it according to a physician's predictions. For this patient, you can total the scores on the left, and then modify it with prediction on the right, and then come up with a total of 15 points. This puts the patient at a median survival of less than 1 week. Now, given these 5 prognostic data points, you can reasonably conclude that the patient's prognosis was on the order of days, possibly even hours. So after formulating a prognosis, the next step is actually communicating that prognosis to the patient. There are several ways to go about doing this, but one of the most common ways involves this four-step process of preparation, content, patient or family response, and closing. We'll take each in turn. The first step in communicating a prognosis is the preparation step. First, research the patient's condition to determine prognostic parameters with and without therapy, for example, life-prolonging and palliative. Then, arrange a meeting in a private place with ample time, seating, and tissues, and no interruptions from phones, pagers, and staff. Alert the patient ahead of time that you need to discuss important aspects of his or her health. At the meeting, first establish how the patient is feeling, identifying symptoms that can be the later focus of discussion of palliative therapies. Establish the patient's understanding of his or her illness. Ask what the patient hopes you will be able to do. Establish what the patient wishes to know from you about their illness. The next step in communicating a prognosis is the content step. First, tell the patient that you have bad news to share. Give a warning shot. State the news clearly, simply, and sensitively. Provide information in small amounts at a time. Make optimistic statements that are truthful. And anchor the survival estimate you communicate in previously published data and modify it by the patient's current clinical status. The next step in communicating a prognosis is responding to the patient. First, acknowledge the patient's affect and express empathy. Then, assure the patient of your continued involvement in his or her medical care. Squarely address the issue that foregoing disease-directed therapy does not create a therapeutic void. Patients often conflate doing something with treatment like chemotherapy. The final step in communicating a prognosis is the closing step. First, summarize the new news sensitively and outline a short-term plan of care. Then, arrange a follow-up visit, even if the patient is being referred for hospice care, since it is a tangible example of continued commitment to the patient. Next, offer to discuss the news with people important to the patient who are not present. And finally, provide the patient with the means of contacting you and your team in an emergency. Returning to the case study, her post-ICU course resulted in comfort measures only, which was then initiated. 1 week later, the patient had not died and seemed to have stabilized. And although she was nonverbal, the patient seemed to have some meaningful interactions with the family. It appears then that the patient's course has stabilized. Given that the patient had not died, this brings up an interesting question. We know that physicians tend to overestimate survival, but how often do MDs underestimate survival? That is, how often do we underprognosticate or are overly pessimistic? So question, how often do clinicians underestimate survival? A, never. B, less than 30%. C, 30 to 60%. Or D, greater than 60%. A study a number of years ago looked at 468 terminally ill hospice patients, of which 77% had a diagnosis of either cancer or AIDS. The median performance status was an ECOG of 3. 343 doctors gave survival estimates on these 468 patients, and these are the results. The diagonal line represents perfect prediction. Predictions above the line were overly optimistic, and those below the line were overly pessimistic. Defining accurate predictions as 0.67 to 1.33 times actual survival, we find that about 17% of predictions were overly pessimistic. This is a similar study, but the difference is that these patients were evaluated in a hospital setting, and all predictions were made by the palliative medicine and comfort care team. 65% of patients had either a cancer or neurologic diagnosis. 429 predictions were made, and these are the results. Correct predictions are the colored black dots. Overly optimistic predictions are below these dots, and overly pessimistic predictions are above these dots. We find that about 16% of predictions are overly pessimistic, similar to the previous study. So then, there is a new dilemma with this patient. How do we go about informing the patient's family of our incorrect prognosis? In many ways, it's no different than delivering bad news or any prognosis for a life-limiting condition. You need to prepare for the encounter, you need to deliver the information, you need to evaluate the response, and you need to summarize. Of course, this is easier to do if the original prognosis was tempered with the idea of individual variation. So taking our prior approach, we can modify the steps to deliver a corrected prognosis. In the preparation step, research the patient's condition. Arrange a meeting in a private place. Alert the patient or family that you need to discuss important new information. Identify further symptoms and note current level of debilitation. Establish current understanding of illness, and then reestablish hopes and wishes. In the content step, tell the patient or family you have new news. State the information clearly, simply, and sensitively. Provide information in small amounts. Make optimistic statements that are truthful. Make new survival estimates based on change in clinical status. In the patient or family response step, acknowledge the patient's or family's affect to the new information and express empathy. Respond to new emotions with compassion and understanding, and assure the patient or family of your continued involvement in the medical care. In the closing step, summarize the new news sensitively and outline short-term plan of care. Arrange for a follow-up visit. Offer to discuss the additional information with people important to the patient or family who are not present, and provide the patient or family with the means of contacting you or your team. After one is able to approach the family and deliver the news, there are some challenges to care that you must consider. There are important questions to ask regarding transitions in care when the prognosis changes from short to longer. It depends on what the new prognosis is. Do you keep the patient in the hospital? Do you discharge the patient with hospice? Do you send the patient for rehab? And there are financial implications. Would the family be responsible for a hospital stay? Would the family be responsible for a skilled nursing facility stay? This is not an exhaustive list of all the emotions involved with changes in prognosis and what has been termed the failure to die syndrome, but these are the most common ones that are important to address. On the one hand, there's relief that the patient has not died, but on the other hand, there is also a corresponding guilt as to why the patient has not died. There is often a prolonged grieving process as the patient's prognosis is extended. There is often distrust and frustration at the physicians and the medical system. There is also an underlying current of anger as the team needs to bring up topics such as disposition and continuity of care when a patient is deemed not to be imminently dying. The term emotional roller coaster is very apt for these situations, and a skilled interdisciplinary team is required to effectively manage the strong emotions. Let's return to the case study, her end-of-life care. Although family wanted the patient to stay in the hospital, the insurance would not allow it. Unfortunately, the family could not afford the cost of a skilled nursing facility. The family decided to take the patient home with hospice care, and the patient died 5 weeks after discharge, or about 7 weeks after her stroke, in comfort at home. Hopefully, this presentation was able to give you the basics of prognostication. I want to thank you for your time and attention. Are there any questions or comments that I can help?